Ladies and gentlemen, thanks for attending this week's Grand Round. My name is David Till. I'm a consultant in diabetes and endocrinology, if anyone doesn't know me. And I'm going to be handing over in a moment to Fiona Leggett, who's one of our diabetes inpatient specialist nurses. We're presenting this week, particularly because it is Insulin Safety Week. So it's always important to be thinking about diabetes and insulin, but if we could just try and focus everyone's minds a little bit this week. And I think Fiona is going to give us a whistle-stop tour through a few salient and important points that we pick up all the time on the wards that people are maybe struggling with or not getting to grips with about diabetes care and management, the importance of the correct diagnosis, the medications, in particular correct insulin types. And obviously we're recording this, so we'll be able to share it for those who aren't able to attend in person. But it is now 100 years since we have had access to insulin. This talk will commemorate that and go on to say a little bit more about what we are about within inpatient diabetes. And without further ado, I will hand over to Fiona. Thank you.
Thank you, David. Hello, everybody. Basically, I'm going to do, as David said, a whistle-stop tour of diabetes. So first, we're going to look at what we're going to cover. We're going to look at types of diabetes, etc. Okay. Key things also COVID-19 and diabetes, which unfortunately is still going. So types of diabetes, everybody thinks they know what these are. So we've got type 1, type 2, we've got MODY, maturity onset diabetes of the young, we've got LADA, latent autoimmune diabetes in adults, 3C diabetes, which is due to pancreatic damage, drug or chemical induced diabetes, usually steroids. It's the main culprit that we see in hospital, and gestational neonatal diabetes. So there's about 4.9 million people in the UK that have diabetes. About 8% have type 1. They're basically producing no endogenous insulin, so autoimmune response, pancreatic beta cell destruction. They're dependent on insulin to survive, which is why it's so key when we have our type 1 patients in hospital to never, ever, ever omit their basal insulin. Often you see this being held because they've had a hypo, but that basal insulin with our type 1 diabetics must never, ever be omitted. So if you take one thing away, please take that away with you. And their major management is insulin. Type 2 diabetes, this is the bulk of patients that we see. It's 90% of people with diabetes have type 2, and probably about 2% of the more rarer type, which is the MODY and the LADA and the 3C. Often management here is diet. It's really key. A lot of people with type 2 diabetes are overweight, so weight loss is a major element, exercise, oral hypoglycemics, and a lot of patients are on insulin. And also injectables, such as the GLP-1s. So when we're looking at medications, obviously we've got insulin, got metformin, probably the most common drug used. So most people coming in, their metformin is usually held. We've got sulfonylureas, most people know gliclazide, pioglitazones, and we've got the DP4 inhibitors, which is linagliptin, sitagliptin, and we've got the GLP-1 receptor agonists. So these are our subcut injections. They are given either weekly or once daily, and they encourage weight loss. And we've also got our SGLT2 inhibitors. These also should be held when people are coming into hospital acutely unwell, because there can be an increased risk of glycemic DKA. So that's something that's really important. So just quickly running through, we've got our biguanides, so metformin, which as we know is the most common drug. That's first line medication with type 2 diabetes in every case. They can't tolerate the standard metformin, then we normally switch over to the moderate release form, which generally has less of the GI side effects that are very common with metformin. It's very rare that it can cause lactic acidosis, but it is something that we are still vigilant with, and often it's held. We've got our sulfonylureas, so as mentioned earlier, there's glipizide, glimepiride. So they work in the following way: stimulate insulin secretion. Often there's a lot of weight gain with these, so they're not the best drug if people are overweight in the first instance. We need to be quite careful with these medications in our elderly population, mainly because they can contribute to hypoglycemia. So patients who are on these in hospital, please look whether they're on glipizide and reduce the dose. So we've got our gliptins, sitagliptin, linagliptin. Linagliptin is quite a useful one to be aware of because often this is used with patients with very poor renal. So it can be used in any sort of GFR really. So it's quite a useful medication to use. However, none of these medications should be used if the patient has any history of pancreatitis. We've also got our SGLT2s. So these are, I suppose, one of the more sort of newer agents on the market, but still have been around for a while. Very useful. They aid weight loss, which is key in our type 2 overweight patients. You need to be careful in elderly patients, and certainly when people are unwell, as I mentioned earlier, this medication must be held when they come in, and often it isn't. People remember to hold metformin, but they don't remember to hold the SGLT2s. So if you see anyone on a Flozin medication, then please make sure that medication is held, usually for about a week or so, until they're sort of well again, and then they can return back onto the medications. So this is our GLP-1 agonists. These are weekly or daily subcut injections. They are not insulins. They basically help to reduce appetite as it slows gastric emptying, and it does not cause hypos, which is really useful. So next we're looking at types of insulins. So we've got our short-acting, rapid-acting in the green. The blue are our sort of intermediate or long-acting insulins. We've got our mixtures. So we've got Novamix 30, Humalog Mix 2550. The numbers represent the ratio of fast-acting. So Novamix 30 would have 30% fast-acting and 70% intermediate. And the sort of army green colour are the sort of very long-acting basal insulins. Often can last up to sort of 48 hours. So as it's Insulin Safety Week, we're going to go through the 6 R's, which are really important. So the first one obviously being the right insulin. So just a snapshot of some of the insulins available. So we've got our fast-acting, the long-acting and the mixed. It's very important with the mixed that the insulin is shaken to kind of mix it up. And what is key with the right insulin is also when patients are being discharged in their discharge summary. Often we've seen people being discharged on Novamix 30 when actually they're on Nova Rapid. So it's really important when you're doing those discharge summaries to ensure that it is the right insulin for the right person, okay? Easily mistake to do when you're dropping down. So please make sure that it is the right insulin that is on that discharge summary and that is being prescribed. So next on our 6 R's, we've got right time. So it's very important that insulin is timed appropriately. If you're on a rapid acting insulin with meals, we normally would prescribe it just before or immediately after the meal, usually given 3 times a day. Long-acting insulins are usually prescribed once. On occasions they are prescribed twice daily, but to be ensured that they are given at the same time each day. And again, with the mixed insulins, make sure that they're timed with a meal because they're mixed. There is a risk of a hypo if they're given and then the patient goes on not to eat anything. So it's really important to think about timings of insulins when we're giving them. So the next R, we've got right device. So just a snapshot of pictures of what the insulins actually look like. If you're still using the paper chart, which sometimes in ANU they are, then obviously all the insulins must be prescribed on page 4, not on the sort of regular medication pages. What's really useful now with the EPMA is that it gives a picture description of each insulin, which is really useful, and it makes it easy to check whether you're prescribing the right insulin. If ever you are able to, please confirm the dose with the patients, because they know their insulin better than we do. And often patients are on quite high doses. So it's good to always check that, but also to actually take into consideration what the patient is saying. Insulins now, they come in different units per mil. So we've got some insulins that go up to 300 units. So we can see on here the Toujeo is 300 units per mil. That has no difference to the dosing. Okay, so the dose is the same with that as it would be if it was an insulin that's 100 units per mil. So the actual dosing up is the same, it's just the actual volume. So they're drawing up less. And the maximum amount that people can draw up with 100 units per mil is 50 units. Whereas if they're drawing up from a 300 units per mil pen, they can actually draw up to 150 units because it's still half a mil, and that can be given in one go. So when we think about administering the insulin, it's about no more than half a mil at a time. Okay. Also, if we're writing on the paper prescription chart, it's always important never to abbreviate the units to U, because that can be miscalculated for a 0. So there could be, instead of 10 units, it looks like 100. So it's really important not to abbreviate the units and put units. But on the EPMA, obviously, this is not a problem. So again, we're looking at right dose. So these are things that I've just covered. Really important to make sure that we are getting all of these things right, not just in Insulin Safety Week, but every single week, every single day that we are seeing patients on insulin. So we're looking at right route. So we're giving in the abdomen. We must make sure that we're giving it away from the belly button. We've got the upper outer thigh area, and we've got the sort of buttocks area. A lot of patients generally give it in the arm, which is not the best route. If you are giving it in the arm, it needs to be right at the back, sort of in the muscle area. It's quite awkward. So most of the time we recommend that it's given in the abdomen and the upper outer thigh area. It's really important that patients change their needles every single time. A lot of patients do not do that, and when they come in and we see them, if they're giving their insulin, they suddenly start hypoing. It may be because they're not changing their needles so vigorously at home. So that's something that we really try and stress the importance of. Insulin should never be drawn up from a cartridge or a disposable pen, which will always be, if they're on vials, obviously drawn up from the vial, but most people will be using either a reusable cartridge pen or a disposable pen. We avoid intramuscular injections, and blood sugar should always be checked regularly. So usually 4 times a day in hospital. So right route. So, you know, patients coming in, DKA, nil by mouth, other protocols that we need to put them on. For example, they've had an NSTEMI, then we need to make sure that they're going on to intravenous insulin. So there's lots of different protocols. Please familiarise yourself. Okay, the nil by mouth protocol is a nice bright green colour. The ACS is bright yellow. DKA, HHS protocol is white and orange. And the maternity one, which is not used in this hospital, is sort of white and purple colour. So blood sugars will be checked hourly. Ketones will need to be checked, especially if they're coming in for DKA, until they're down to 0.6. Potassium is really key, so it needs to be checked via VBGs or via using these once they're a bit more stable. Insulin should never be run dry, always should be run with saline, and if glucose, dextrose needs to be added in, it will be added into the same Y-shaped connector that the insulin is being run through. So never just have insulin running through. Okay. And last but not least, we've got the right patient. So it's really important that we're not just giving the insulin to anybody. We need to make sure that it is the right patient and we are giving the correct insulin to that patient. that's the 6 R's covered. Now moving on to diabetes complications, DKA and HS. So often we see patients coming in with DKA. This protocol, I urge you to get familiar with this protocol. It might look very busy, but all the information that you need, everything that you need, is on this protocol. Fluids are already written up for you. The exit criteria is written up for you. Stepping down if they've moved out of DKA or HHS, but they're not eating, so they need to go on to a step down variable rate insulin infusion. Everything is on this protocol, but people often just do their own thing because I don't know whether they get into a bit of a flap, but please just follow the protocol. It's got every information that you need. You don't need to write up the fluids. The fluids are written up for you. You just need to sign them and go down them as they are on the protocol. So what exactly is DKA? D is for the diabetes, which is a blood glucose concentration of over 11 millimoles, and they're known to have diabetes. The K is for ketonemia or ketonuria, capillary or blood ketone concentration of over 3, or they've got significant ketonuria. Okay, so more than 2+ on the urine sticks. If that is the case, then please try and get a blood ketone. And the A is for acidemia, acidosis, a bicarb concentration of either less than 15 or venous pH of less than 7.3, or some cases you'll have both. But this is what DKA is, not 1, not 2, but all 3. Okay, so it's very important that we're meeting the criteria before we go reach for that DKA protocol. So management, we're running through fixed rate intravenous insulin, which is made up of 50 units of actrapid in saline, usually to put that 50 ml insulin syringe. Okay, so the fluid replacement rate is very clear on the protocol. So this is how it runs through. Obviously, the rate would need to be adjusted slightly, especially if they're elderly or they've got any acute renal disease or history of CKD. If they're under 18, then we need to be looking at the paediatric DKA protocol. If they're under 18, they may well need to be directed to the paediatric team based over at Conquest. Okay, so liaise with the diabetes team. Okay, let us know that the patient is in, then we can come and monitor them. If they're on subcut insulin, then we continue with the basal insulin and hold the Nova Rapid if they're on a basal bolus, because they'll be getting the Nova Rapid through, or Actrapid rather, through the variable rate infusion, fixed rate infusion. So we never omit the basal insulin if they're already written up for it. And if they're not written up for it, then it will be prescribed once we have reviewed them. Okay, so these are the things that we need to be looking out for. We're looking at VBGs, usernese, and that will then obviously be reduced time-wise as they recover and get through DKA. Once they have started eating and drinking reliably, then once they are out of DKA, so they're no longer acidotic, ketones are back to the normal range, i.e. below 0.6, then we usually recommend that they have some Nova Rapid with the next meal. Then they eat their lunch or whatever it is. 30 minutes later, the insulin infusion is then taken down. So the whole protocol regime is taken down, and then they are closely monitored afterwards. It's very important that we look at why they came in with DKA. You know, is it because they're not taking their insulin? Are they a new diagnosis? What exactly prompted them to go into DKA? So we also have euglycemic DKA. So basically the blood sugars are running, you know, within sort of reasonable range. And this is quite a rare condition, but we are seeing it more and more. And often I think because patients are being put on the SGLT2 medications a lot more often these days. So as I say, these are the flow-ins, and when patients come into hospital, these need to be stopped or held. If someone goes into DKA and they're on these medications, then that medication would not ever be restarted and a yellow card would need to be done. These patients would need to be treated using the DKA protocol. Okay, but because their blood sugars are within the sort of normal range, then they need to have a dextrose substrate running through, and that's just on the box on the protocol where the blood sugars drop below a certain level. We would set up the glucose anyway. So why do they get this DKA with these types of medications? And it's always when the patient is unwell. The decreased insulin production and an increase in secretion of glucagon is the main sort of cause. So basically, the relative lack of insulin stimulates the production of free fatty acids in ketone bodies and a shift from glucose to fat metabolism. And this basically causes ketoacidosis. So the main treatment for them is this DKA protocol. Okay. So not that common, but we're seeing more of this, so it's important that people know about it. We've also got HHS, similar to DKA, similar presentations. People are coming in with very high blood sugar readings, but the main difference, which we'll go through in a minute, they very rarely have ketones, so their treatment may just be with fluids. So let's have a look a bit more into this. So hyperosmolar hypoglycemic state. So we've got hypovolemia, got hypoglycemia. So often their blood sugars are very elevated and they've been running high probably for quite a long time. They've been feeling rough probably for a while and not really realizing why. Often their ketones are below 3. They may or may not have acidemia, but the osmolarity will be very elevated. And calculate the osmolarity with 2 times the sodium, plus urea, plus glucose, and then plus potassium. So if we look at the similarities or the differences between DKA and HHS, any age for DKA, HHS usually over 60. Presentation with DKA is very quick, whereas with HHS it can be much more prolonged. Mortality with HHS is quite surprising. It's very high in comparison to DKA. So HHS is a very serious condition that we need to really address. Similarities in regards to glucose and osmolarity. Sodium in HHS is usually very high or normal, whereas with DKA it's on the low side or normal. And the bicarb, not much of a change there with HHS. And the ketones is much more obvious with DKA. So the management is the same, okay? Same as DKA in that they need to go onto the HHS protocol, which is on the flip side. So you've got the DKA protocol on one side, on the other side you've got the HHS protocol. So it's the same in that they need insulin. Well, they need insulin if they have ketones. Often with HHS, if there isn't any ketones, we can just treat them with fluids. So it depends on whether they have ketones or not. If they don't, then fluid replacement is the key treatment. If they do have ketones, then they will need to go on to a fixed rate insulin infusion. The main difference with that is that the rate of insulin going through is much less. Okay, so it depends on their needs. But fluid replacement is key for both DKA and HHS. With HHS, there is a VTE risk, so sometimes heparin needs to be looked at. We need to look at what the precipitating cause is. Obviously, look at in caution with age, because these are often older patients, and look at their comorbidities. We exit the HHS protocol once they are eating and drinking, and once their osmolarity issues has resolved. So that's the main thing. And at the same time, we want to prevent cerebral edema, which is why looking at the fluid rate is very important in relation to any comorbidities. So tips on IV insulin administration. So as we've said, and we'll keep saying, always continue the basal or intermediate acting insulin in patients with type 1 diabetes, even if they're on IV insulin, because what happens if that IV insulin gets stopped, cannula gets, we can't use it. So basically, if I haven't got that background insulin going through, they're going to go back into DKA again. So it's really important to keep that in mind. Always ensure that the appropriate fluids are running through. And as I say, it's on the back of the protocol. Monitor blood sugars, ketones. If they become hypoglycemia, then it's probably best to stop the infusion for about 10 to 15 minutes and recheck. Okay. This may signal a change in what fluids are going to be administered. Do they need to then have dextrose added in? Does the algorithm or rate of insulin needs to be reduced? So this is a time where things need to be stopped and looked at. And as mentioned before, that the insulin infusion continues for 30 minutes once they have started to eat and drink, and then we are in the process of taking down the infusion. So we always wait until half an hour from them having that insulin dose. So we don't take this down at any time of the day. We always take it down with a meal. Okay. Okay. So hypoglycemia, we see this a lot. Often patients do have symptoms of hypo, sometimes people don't. So if you see or hear of a patient that's having very sweaty, or they're very shivery, shaky, can't quite focus, lack of concentration, it's really important that we check their blood sugar. And if that blood sugar is less than 4 millimoles, then we need to treat using our hypo box, which should be on every single ward, and everything in there should be in date and stocked up. It's always worth looking at why that hypo happened. Is it because they missed or delayed their meal? Have they had an inappropriate dose of stat insulin, which has caused their blood sugar to drop down a bit too much? Are they on sulfonylureas, glycoside, for example, which can cause hypoglycemias? It's very important that people are eating when they're on hypoglycemias and, when they're on sulfonylureas and certain insulins. So we need to make sure that we're looking after what people are eating. In the past 2 years at Eastbourne Hospital, we've had 2 patients suffer permanent brain injury due to prolonged hypo. So it's really important that we get this right straight away. So definition, blood glucose less than 4 millimoles, and this is what we need to be doing. This protocol should be on the hypo box. So if they're conscious and orientated, able to swallow, then we basically give them some oral treatment, and then we recheck the blood sugar after about 10 to 15 minutes. The reason that we give this treatment is that it is quick acting and that it adds up to about 15 to 20 grams of carbohydrates. So if someone's at home, that would equate to about 4 jelly babies or 4 dextrose tablets, 4 to 5. So it's really key to getting that dose right. So we recheck it, blood sugars afterwards should be over 4. If it isn't, then we repeat that process. They have another lot of glucojuice or another lot of glucose tabs. And then we follow that up with a meal if it's due, otherwise they have a snack. If the patient has been given glucagon, then we need to give a double carb portion because it has a much huger effect. So that's really important. So obviously glucagon can only be used once anyway, but if it has been used, then we need to give a double carb portion. If the patient is conscious but confused or disorientated and unable to swallow, then providing airway and everything else is okay, then we need to treat that with 20% dextrose infusion. If no IV access, then we give glucagon, and obviously we arrange an urgent medical review. If we don't, you do, and please refer to us. If we don't know the patient or need another referral, recheck. If it's less than 4, then we need to give another 20% dextrose, and that can be done up to 3 times. If it remains below 4, then please contact the diabetes team or on-call medical reg. So it's really important that we get this right. Okay, we can't just go, oh yeah, it's 3.9, don't worry about it. It needs to be acted straight away, so that we can get those blood sugars up and reduce any risks going forward. Okay, if you have a type 1 patient that has hypoglycemia, you do not omit their basal insulin. And if they're eating a meal, we should not be omitting the Levorapid. The dose can be reduced, but it needs to be treated first, and then they have the insulin with a meal. Okay, we do not omit the basal insulin. Now, we see it time and time again, so please, please do not omit that basal insulin. Okay. So on the other side of the scales, we've got hyperglycemia. So basically CBGs that are persistently over 11 millimoles. Just to go back to the hypoglycemia, sorry, it's really important that actually their insulin doses are reduced, especially if they're having quite a lot of hypos. Really, if anyone has a hypo, we should be referred to so that we can assess their insulin. And we would normally recommend a reduction of 10 to 20% of the insulin. So that's something that can be done on the wards, and please refer to us. Back to hypoglycemia, so CBG readings over 11 millimoles. So we need to look at what the cause is. You know, they're in hospital. Is it because they're unwell? Is it what they're eating? Often patients come into hospital and they eat things that they would never dream of having at home. They have 2 puddings a day. They're having juice with their breakfast. So please, let's look at what they're eating. Often it's the first question that I ask when I go and see a patient on the ward. What are they eating? Is there a pattern in why it's going up? Also with hypoglycemia, we need to think about the patient in front of us, okay? We need to be looking at ketones with type 1 diabetes, if their blood sugars are over 14 millimoles. Patients with type 2 diabetes, are they on these SGLT2 inhibitors, and are they still on it? Okay, if they are, why hasn't it been stopped? So hold it. Every time you see it along the way, stop the SGLT2s. And we need to be checking their ketones because their blood sugar readings might be fine, but they may be having glycemic DKA. So it's really important that we check ketones on type 1 patients. Their blood sugars over 14. And these patients that are on the SGLT2s, okay? Also, it's probably worth doing it in a patient with type 2 diabetes. Their blood sugars are persisting in the 20s. Well, let's maybe just do a one-off just to make sure we're not missing something. Please try and avoid PRN insulin. I know sometimes we need to give it, but often it's given during the night. The poor on-call doctor's like, okay, I need to do something. You know, we're not giving it safely. We're giving it at night time. There's the high risk of hypoglycemia, and we often see these massive drops in the morning. So if we need to give a stat dose of rapid-acting insulin, number one, we never give Atrapid. Atrapid takes up to about 8 hours duration. Well, that's not fast-acting, is it? So you want to give Novorapid. It's going to be working pretty quickly after about 20 minutes, 30 minutes, and out of the system, hopefully in 4 hours. So you want to use Novorapid, never Atrapid. Okay, that's another point. And please try and time it with a meal if you can, so that we're doing it safely. Look at the patient, not just the blood glucose level. You know, are they really elderly? Do we need that strict blood glucose level of 10s, 12s, even 14s in patients that are in their 90s? You know, let's just see what's going on. Do we need to act on that high blood sugar straight away? Okay. So let's try and get a picture of why this is happening, what's going on. Have they put on feed? You know, are they on Fortisip and all of a sudden their blood sugar's going up? Are they on steroids? All of a sudden their blood sugar's going up. Let's really look at why this is happening and see if we can, you know, we can put a plan so that this is being dealt with. Obviously, please refer to the team. That's why we're here. Okay. So hypoglycemia. Also, as with hypoglycemia, we would reduce the dose. With hypoglycemia, if their pattern is emerging and they're running high, why don't we look at what medication they're on? Can their medication be titrated up? Can their insulin be increased? You know, again, 10 to 20% increases are going to be relatively safe. If you're unsure, then just do 10%. But, you know, do something. Let's do something. Try and get it up, and then we will obviously review them. Okay. Okay. So the other thing, just going back to Actrapid, is we need to be mindful of patients with renal issues. You know, people who've got CKD or acute drop in their renal function whilst in hospital due to illness. Actrapid, because it lasts that bit longer, if their kidney function is not brilliant, it's going to stay in the system so much longer than it needs to. So therefore, we're putting them even at further risk of hypoing later on. So it's not the drug to use. Okay, so get Actrapid out of your head. If we need to be using something, we use NovaRapid. So COVID-19 and diabetes. So often patients are coming in, you know, over the past couple of years, even now, patients coming in needing to be put on dexamethasone. This would have a massive impact on their blood sugar readings. Prednisolone usually has a profile where the blood sugar will go up in the day and generally will come down. With dexamethasone, it generally is higher most of the time. So you get this 24-hour picture of sort of high blood sugars. So please refer to us, okay, if they're going to be put on dexamethasone. We need to be thinking about what the appropriate medications is. So it may be putting them on a sulfonylurea, such as gliclazide. It may be starting them on insulin, such as Humulin I or Insulatard. So we can look at that. Okay. If they've got COVID-19, sulfonylureas are actually not recommended. So it's slightly different if patients are on steroids without COVID, we would recommend sulfonylureas. If they've got COVID-19 and diabetes, then we do not use sulfonylureas, okay? We would put them straight onto insulin. The other thing to be aware of is when these blood sugars are being taken in hospital, the highest blood sugar that the machines can take is 27.8. So if you've got a blood sugar coming up on a machine, or someone says, oh, the blood sugar is 27.8, there must be a VBG done, because that patient's blood sugar could be anything. It could be 40, it could be 50, it could be anything. So we don't know what we're treating. We don't know what it is. So if the blood sugar machine is coming up at 27.8, a VBG must be done, and glucose. A VBG only goes up to about 43 millimoles in regards to glucose. So if it's higher than that, it may come back as incalculable. So please, please, if their blood sugars are 27.8, you must do a VBG, okay? Okay. So quick scenario, but I'm just talking to myself. End-of-life care has commenced, because this comes up a lot of times, end-of-life care, usually on Tresiba 30, NovaRapid with meals. So they're no longer eating. What do we do with their insulin? So if they're type 1 and they're not eating, they don't need the NovaRapid with their meals, because NovaRapid is only giving if the patient is eating. So we would stop the NovaRapid. However, their Tresiba would need to be continued, because they must have that basal insulin going through. The dose might need to be reduced, and obviously we would need to be involved in that, but we would never omit this insulin, because otherwise we're putting them at risk of DKA, and that is not the best way. That is not good care for us with patients that have commenced end-of-life care. If it's a type 2, someone with type 2 diabetes, then we would stop all medications, including the insulin. So it's very important that we know what kind of diabetes the patient has. So it's not good enough just write in the notes, the patient has diabetes. We need to know what kind of diabetes they have. Do they have type 1? Do they have type 2? Are they LADA? Are they MODY? All right, you might not know that, but at least let's find out if they've got type 1 diabetes, because that's going to be key in regards to any forthcoming treatment, especially in a situation where they're end-of-life care. So just to recap, the key things that people do not do, or things that we are like, oh, please do, are things that we have raised. So please do not use Actrapid, use NovaRapid, and use it wisely. Time it with a meal. Does this patient need it right now? Look at the patient, not the number. Blood sugars, 27.8, I need to do a VBG. Ketones, am I checking ketones in my patient with type 1 diabetes whose blood sugar is over 14? Check the ketone. If the ketone is raised, okay, so the ketone is over 3, or they've got ketone urea, got a positive dip test, we must do a VBG. We need to make sure that they're not acidotic, okay? So that pretty much sums up the key things that we would like patients to do. We would like the doctors to do. We'd like patients to do a lot of things. We would love the doctors to do. And also, please read our entries. Often we put something in the notes, and then the next day it's, I'll get the diabetes nurse to review. We've already reviewed them. So please read the notes and take note of this presentation. Thank you so much for your time. It is much appreciated, and have a great Insulin Safety Week. Thank you.
Thank you, Fiona. That was excellent.
Thanks very much, Fiona. We'll get that up on the YouTube channel straight away.